Thank you, sir, for a very kind introduction. Thank you so much. Truly honored. Now, what happens when we look at a patient who has a choroiditis? The confusion arises, we don't understand whether it is infective or non-infective, or even more important, is it choroiditis or something else? I will show you the examples how we can all get confused. So I think it's important to answer few questions to yourself, and they include: first, see the pattern recognition. That is the utmost important, and all my cases will highlight how to be a good clinician. Is it choroiditis or is it retinochoroiditis? Is there any associated involvement of the optic nerve head or retinal vessels? Does the clinical feature fit into something you know of? Is there associated inflammation? Is it unifocal, multifocal, unilateral, bilateral? Any systemic disease? Is it recurrent? And what was the previous episode like? And is it responding the way it should? Now, I would show you how these cases will help you in clinical practice. This is a 29-year-old lady. She has received intravitreal triamcinolone, received oral steroids, and even anti-TB before she came to us. Her vision is counting finger. Now, the first question was, what is the pattern? It is retinochoroiditis. As you can see, it is the retina which is primarily involved and not the choroid. So if it is retina primarily involved, it cannot be TB, because TB primarily involves choroid. She has an overlying vitritis. It is a unilateral disease, but as I mentioned, always try to see what happened in the past. This is the past photograph which she was carrying with her. And the moment you look at it, you say, oh, this is toxoretinochoroiditis. I think all of you will agree this is kind of book picture, because what you have is the retinitis, which is localized, vitreous cells on top of it, fluffy margin. It's the headlight in fog appearance. We got confused with the choroiditis, and we started looking for TB and giving steroids and doing, and that is how you ended up in a situation like this. So this patient, when she came to us, we took her up for surgery, and the vitreous shows these toxocysts. But if somebody had recognized the pattern right in the beginning, we could have saved the visual loss. Now comes another case. This also is macular choroiditis, but this is very different. This is not retinitis. It is primarily, the lesion is involving the choroid, and this has what we call a ground glass appearance. It's very, very uniform throughout. There is no vitritis, but the character is, it is placoid. So if you are seeing placoid variety, ground glass, what do you think of? You think of only one disease on earth, and that is syphilis. So you just get a syphilis test done, and if you want to differentiate it from serpiginous choroiditis, this one does not have an active edge clinically. The whole thing seems just a placoid, but it's a ground glass placoid. And when you do, what next? The next would be, of course, the fluorescein, and even when you do the fluorescein, it's ground glass. It is not the fluorescein of serpiginous choroiditis or other choroiditis which have healing in the center and the edges are different. This is uniform. This is kind of ground glass. So if you have this, don't think of doing any other investigations, only syphilis. Even if the test come negative, no harm in keeping test for syphilis, because if it walks like a duck, talks like a duck, it got to be duck. So the pattern recognition is extremely important. Another pattern which we always see is, for example, this is involving the macula for sure, but when you do the autofluorescence, you realize the lesions are peripapillary, finger-like, they have pseudopodia-like projection, they are not multifocal, they are all one in continuity, and They are progressing along the edge. If you see, this is the edge which is progressing. This is the lesion which is healing. This is something classical serpiginous choroiditis, which is likely to be autoimmune in nature. So, you can always decide on your management. This is just to show you autofluorescence, that it is progressing along the edge. Then we come to something which we call serpiginous-like choroiditis. Now, if you look at these lesions here, there is healing in the center, and the edge which is active, which is yellow, there is multifocality. You see one focus here, and it's a unilateral disease. There may not be overlying vitritis, but if it is present, this is also important. Patient also has scleritis. Now, which condition will produce this kind of serpiginous-like choroiditis and scleritis? It's actually only TB. So, get investigated just for tuberculosis. And of course, this is to show how it is different from the ground glass placoid appearance of fluorescein. Here, when you do fluorescein, and this one here is ICG, but you have the edge which is hyper, and in the late phase that hypo becomes hyper in the late phase. In syphilis, it was just uniform ground glass appearance. And this patient only, we have a positive Monteus, we have quantiferon, and the chest shows some mediastinal lymph nodes which show a beautiful TB granuloma. But this patient actually doesn't need a panel of tests. Once you decide on what pattern it fits into, just get the tailored investigations. And this is the same patient responding to anti-TB and corticosteroids. So there are some phenotypic expressions between serpiginous, which is autoimmune, or the serpiginous, which is like TB. The serpiginous, which is like TB, tends to be unilateral, may have associated inflammation. It usually begins in the posterior pole and not peripapillary, like I showed the previous case of classic serpiginous. It has to be multifocal, and there will be pigment clumping at the center, and the lesion will be active along the edges. So if you see any one of these, think of infective or a TB variety of serpiginous-like choroiditis. As I said in the beginning, that there has to be caution before you label these patients as choroiditis, because many a times you come across cases which are not choroiditis but which are labeled as choroiditis and exposed to steroids. I'm briefly going to show you two cases. Now, this is the patient which is being treated for TB choroiditis, and she complains of worsening. Now, if you go back to your anatomy, very basic, the choroids are arranged in their architecture is such that they have lobules. So if the lobule is inflamed, it will be focal. If the multiple adjoining lobules inflame, they will be diffuse, and that is how the choroiditis is. It is either focal or multifocal. Choroiditis cannot produce a linear lesion like this. So that is against the basic funda of choroiditis. And if on top of it you are seeing this dark, remember this is indicate, I don't have the time to go into the details, but if you see this dark spot, this is more suggestive of fibrinous CSC, central serous retinopathy, because this is the point from where the fluid is coming, and this whole thing is fibrin in the subretinal space. You do fluorescein. Choroiditis is hypo to hyper. Choroiditis is never hyper to hyper. Now here you see hyper and expanding in the late phase, because this is multifocal CSC with fibrin, because the patient has been treated with steroids believing it to be choroiditis. That led to worsening. My second case is this young girl, again referred as choroiditis. But if you see, it is more of a exudation, the heart exudates and not choroiditis, and this is not the pattern of choroiditis, you know. She has a diffuse leak. Again, she had Perry-Romberg syndrome, and this whole thing was a part of it. It is not choroiditis, it's not TB, and this all comes when you learn the pattern recognition. Now, this is the patient hospitalized as IgG4 disease, and he was referred to us as macular choroiditis. But look at this here. I will show you better autofluorescence, the linear lines, which you can better appreciate here. Why should patient of choroiditis have these linear strands? It just doesn't make sense. So you talk to the patient, because in ophthalmology we don't talk to the patient. You go into so many things and look at the OCT. The OCT is involving the outer retina, the pillar-like linear lesions here, very, very classical. This is not even involving the choroid. So even though the patient has an underlying IgG4 disease, there is something happening which is not choroiditis. So what is it? After a lot of struggle and all, we finally found patient had bought a tie, not tie, it's a laser pointer in Goa, and the friends were shining, lighting into each other's eye, and this is something you have to be aware of, the laser-induced maculopathy, because of lots of toys from China and all, they have those lasers which can produce burn, and the recognition is the linear pattern, because the light moves like this, so you have those tracks. So this is my final slide, macular choroiditis. First, be sure it is choroiditis. Once you are sure it is choroiditis, look at the pattern. It has to be diffuse or multifocal. There is no third phenotypic expression. If it is diffuse, think of toxo, because, no, if it is diffuse, see whether it is retinochoroiditis or serpiginous. If it is mainly involving the retina, toxo would be first differential, and viral would be second. If it is mainly involving the choroid, that is chorioretinitis diffuse variety, it will be serpiginous, which can be autoimmune or which can be infective. And I always said these symptoms, how to differentiate. If it is autoimmune, you don't have to start investigating, but if the patient is not responding to steroids, do investigations to rule out infections. If you think of infective, always investigate to rule out infective etiology. If it is multifocal, again, it has a classic phenotype, fits into your pattern of PIC, MUDES, AMPI. You don't investigate in the first go, but if patient is not responding, just investigate. And if it is an atypical phenotype which you are not able to fit anywhere, always, always investigate. Once again, thank you, Professor Atul, for this kind opportunity, and thank you.
Ma'am, we are honored for your
Thank you.
excellent lecture, and I'm sure everyone gained a lot of useful tips.
Absolutely. Solar retinopathy generally has a very small few microns involving the fovea, so normally it doesn't get confused with the choroiditis. Only thing is patient has unexplained visual loss, and if on OCT you see a small hole in the outer retina, discontinuation of the RPE, that just gives you the diagnosis. But majority of people will not start steroids or something, so they will not confuse. Laser maculopathy you can confuse with retinitis or choroiditis, and our patient had IgG4 disease. I wanted to give him IV steroids because I did not know of this entity at that time. So that's why I presented.
Thank you.